Okay, so we're going to cover fever. Here we are. I've just started recording. That could have been a disaster. All right, so any child under the age of 3 months old should always be seen immediately by a doctor if they have a fever of above 38. A child under 3 months old has a very, very immature immune system, and they can't always deal with the things that we can deal with. And any child with a fever above 38 has to be treated as a medical emergency unless proven otherwise. Okay, so any fever above 38, always take them straight to a doctor, or if your nearest pediatric emergency department is nearer, then that will do fine too. But they will have investigations, and they will need to know what it is that's causing that fever. With a fever, it's a common it's a common thing in children, and it's a common thing with anyone actually. And what we need to realize is the fever is there for a reason, and the number on the thermometer doesn't concern us as much as the reason why the fever's there. So if your child could have a fever of 38 or it could have a fever of 41, we're not actually that interested in how high the fever is. It's more to do with why it's there and how it's making your child feel, the underlying reason. Okay, so we see over and over again, you can have a child with bacterial meningitis, which is really serious, with a fever of 38 too, or you can have a child with a very mild ear infection with a fever of 41. Okay, so the number on the thermometer does not correlate to the severity of the illness. All right, so the other thing is that your child the fever is not going to go up to the point where your child is hurt or your child's brain gets too hot. It just doesn't work like that. There is a thing called febrile convulsion that's a completely other subject that can happen when your child's fever goes up too high, but your child is not going to come to any harm with a high fever. Okay, there's always the exception to the rule, but 99.9 times out of 100, the fever is there for a reason, and your child will not be harmed by a high fever. It's a very normal, common response to an infection or a bacteria in the body, and the fever itself is usually not harmful, like we've already said. It's there to fight off infection, and we just want to know why it's there. So signs and symptoms of a fever. The child has a fever when their temperature reads above 38, okay? So they might be unwell or hot to touch, they might be irritable, crying, more sleepy than usual. So when you have a fever, you have an illness behind it, and your immune system is working really, really hard. When I say I mean your child. The immune system is working really, really hard, and it takes a lot out of the body. So that's why we get lethargic. That's sometimes why our appetite gets suppressed. It just, the immune systems all go, and it takes a lot out of the body to do that. Vomiting or refusing to drink. So lots of children might have a vomit with a high fever. Children vomit quite easily. They might refuse to eat or drink. It's fine for them to not eat. They're not going to come to any harm to not eat, unless they're solely reliant on formula. That's different. That's, we'll put that under the class of drinking. They have to drink. Any child or any person, you cannot go without drinking, especially when you have a fever. They might be shivering, they might have some pain, or they could just be what we describe as just a bit flat. They're just not right. They just want to lay about. Sometimes you can see they're breathing faster than normal, and that is a very common sign of fever, because everything gets faster. The heart rate and the breathing gets faster. If you don't have a thermometer, a good thermometer to use is one of these axilla ones, which is the one that just goes under the arm. They're really good. They're what people use in hospital in pediatric settings. They're great. You can get them from most chemists. But a good way to feel if your child actually has a temperature is when you've got a true fever, your head and your torso gets really, really hot, like uncomfortably hot, and your hands and feet often get very cold, because all the blood rushes to the organs in the brain when you have a fever. It's like a survival mechanism. Okay, so that's often what happens with a fever. So we need to that's a way to check. Okay. Baby needs to have frequent small drinks, but not to worry about eating. So this is fine if you have a bottle-fed baby or a child that is, eating normal food and drinking from a cup, then you can quite easily keep an eye on exactly what's going in, and you'll know what's different, and you'll be able to, if that child is unwell for a period of time and you take them to a doctor, you'll be able to tell them exactly what they're drinking. And we go by weight, so you know the doctor will know if that's enough and it's enough to keep them hydrated. A breastfed baby, it's different. Obviously we have no idea really. We know if they're having a full feed when, you know, your boob goes up empty and flat, but with breastfed babies, what you need to keep an eye on is what's coming out the other end. So you need to make sure that those nappies are staying heavy and wet, and that they're having regular wet nappies, and if it dries up completely, if your child's under 6 months and they're having more than a couple of dry wet nappies in a day, then you need to go and see a doctor that day. Okay, the dehydration happens a lot quicker in a smaller body. So you can, like I said with food, just don't push it. What happens when your appetite's suppressed, it's suppressed for a reason. When you try and force feed your child who doesn't want to eat, then what happens is your digestive system has to then kick into play, start digesting food. It takes a lot of effort to digest food, takes a lot of calories, takes away from the immune system. There's a reason your appetite suppresses. We have to trust our bodies in this scenario, okay? You can wipe your child's forehead with slightly tepid water with a cloth, but no cold showers, no cold baths, nothing like that. It won't make any difference. The heat is coming from the virus is detected by the body, and the body releases fighter cells, which then the brain detects those fighter cells and tells the body to heat up. So it's the brain calling the shots, if you like. So by putting a child in cold water, not only is it really uncomfortable and unnecessary, but it's not going to really help. And the brain, you're not going to cool the brain down. It has to be, it's just not going to work. So for comfort, we can pop a little flannel on their forehead, and we can strip them off. We can put a fan in the room, just alternating, not directly on them. Maybe a very light top if they want something on, but we don't need to be blasting them with cold air. If the fever has lasted more than 3 days, it's maybe not a virus, it's maybe a bacterial infection. So viruses, I'm not talking about coronavirus here because it's slightly different and we're still learning about it. But a virus is normally around about 3 days or 72 hours, and then it sort of rides itself out. Whereas bacteria could last for longer and can be more aggressive sometimes. So if his fever's lasted for longer than 3 days and you haven't taken your child to see the doctor, then do that, because it could mean that they need antibiotics. Remember, viruses do not respond to antibiotics. How to take a temperature. So I've already explained, you can get those axilla is armpits, so you can get those axilla thermometers. They do say that they can take rectal temperatures as well, but please don't do that. Dangerous. Only just under the arm is enough for what you need. So I've already explained this. So the immune system senses trouble and releases the fighter cells, and the hypothalamus detects the fighter cells and tells the body to heat up in defense. So viruses and bacteria can't multiply in a hot environment. That's why the heat comes into play. That's why fever comes into play. So the biggest thing I want you to take from this is, number one, trust your body. Trust that the fever is there for a reason. It's not the enemy. And when it comes to giving paracetamol or ibuprofen, we know that paracetamol and ibuprofen will bring down a temperature. However, do we want to bring down a fever when it's fighting a virus or a bacteria? If your child is uncomfortable, the fever is so much that they're just feeling terrible, they're whinging, they're crying, pulling at their ears, maybe they've got a throat infection, they're really sore, you can't get them to eat, absolutely we can give paracetamol or ibuprofen. We're not saying not to give it. If your child is uncomfortable, of course you can give it. But if your child just has a fever and they're just laying, they're a bit flat, they're watching TV or whatever, they're okay, they're not whinging, then just consider that you might not need to give them paracetamol if it's not necessary, because really what we're doing is we're letting the virus take hold a little more and maybe prolonging it a bit. So just have a think before you give it. Do they really need it? Could they do without it for a little while? And just have a think, because really all we're doing is stopping the body doing what it's trying to do. Okay, so all right, so we'll go on to the next thing, which is head injury. Now, head injury is a pretty big umbrella term for quite a big subject. So we're going to sort of fly through this, but this is why I'm recording it, because with head injury, it's the kind of thing, there's so many different areas with head injury. The things we really worry about is concussion and a bleed in the brain, from the brain sort of getting hit against the side of the head, or a severe head injury. So we'll go through the difference and some of the symptoms as well. So what we recommend, the guide, we always follow the Australian guidelines. We don't just make these recommendations up ourselves. It's always medically backed, okay? So if your child has a head injury involving high speeds or heights greater than a metre, falling from playground equipment or whatever, so anything higher than a metre, or the child passes out, or they seem unwell and vomit more than once, then we need to seek medical attention immediately, okay? All three symptoms of these, especially in a child who may not be able to give us a very good history or tell us exactly how they're feeling, they need to be seen straight away. Signs and symptoms of a moderate to severe head injury. So they can be losing consciousness, being drowsy and not responding to your voice, being dazed or shocked, not crying straight after the knock to the head. That's especially younger children. They need to be crying straight away if they banged their head, unless it just wasn't that bad. Sometimes an older child might be confused and memory loss of orientation about time, place, or the people around them. So other symptoms are they can experience visual disturbance, which children from the age of 3 or 4 could tell you about any visual disturbance, any double vision. They can often, in their own way, be able to tell you. If they have unequally sized pupils or weakness in their arms or legs. So this is something that you can kind of look into at home if you're concerned, or if you're really worried, then I would obviously always say get medical attention straight away. But the two things that we would do straight away in hospital is check the pupils. So we'd be looking straight into their eyes and making sure their pupils are exactly the same size. And then the other thing that we would do is take a torch, or just your iPhone torch or whatever, and pop the torch just away from the head and then over the eye and away again, and then over the eye and away again. And what we want to see is that the pupil is getting smaller and then bigger and then smaller and bigger. And so the pupil is reacting, okay? The other thing, and we want them both to be reacting at the same size, and like very similar, they need to be the same size. The other thing that we would do is check any weakness in the arms and legs. And this is very easy even with a newborn. So with a newborn, you would just maybe get them to hold onto your finger and then try and pull away with both hands. And then with their feet, you can tickle their feet and watch them kind of retract very quickly, because obviously that reflex. And then with a slightly older child, 6 months, 9 months, you can hand them a toy and then try and sort of pull it away, or, hand them something that they like to eat. And then with an older child, obviously it's easy. You just ask them to squeeze your fingers, and then you sort of ask them to push against your hands with their feet. So there's a way to do it even from newborn. And that's how we would try and see if there's any weakness in the arms and legs. If they have anything stuck in their head, obviously, I would get help. You would be daft not to. Or large bumps and bruises. So a bump and a bruise, so a lump on the head is very common after even just a mild head injury, but we want to make sure it's not squishy like a beanbag, okay? A lump on the head after a bang should be not necessarily hard, but harder than it shouldn't be squashy, right? So if it's very squashy and it's large, then I would get that seen, okay? Because then what we worry about is actually that the skull has been injured. If they have a seizure, convulsion or fit, that is definitely something that we would be calling an ambulance and be worried about concussion or a bleed. And if they vomit more than once, so more than one vomit is definitely pointing to concussion. So a mild head injury, which is what we'll get most of the time, just where they may display an altered level of consciousness at the time of the injury, but then they're alert and interacting with you. They might have vomited but maybe only once, and have maybe a cut or a bruise on their head, but they're otherwise normal. So that normal cycle of they fall over, they might be slightly dazed for maybe a few seconds, and then they cry, and then you can make them feel better just with a cuddle and a drink or whatever, and then they just run off again and they've got maybe a little bump. That's most of the time is what's going to happen, but that's what we call acting normally. And I wouldn't underestimate your instincts for all these scenarios as well. If you're not convinced, if you think that they're not right, especially with a head injury, you always get them seen, always. And no one knows your child like you do. So if at any point your child starts to act out of character, even if you think they only have a mild head injury symptoms, seek medical advice immediately. If you take your child to see a doctor after a head injury and they keep them overnight, it's because they want them closely monitored throughout the night. And what, obviously the nurses would do every hour, they would check, pupils and weakness and questions and things. So if your doctor thought that your child needed waking at night, they would have kept them in. So if they don't want them woken overnight, then they'll let you go home. So there's no need to wake them. You can obviously sleep with them or, have them in your bedroom if you're worried. But otherwise, by waking them all the time, we're just creating a cranky child. And then the next day, we're not sure if they're just sick or just tired. If they have any of the following symptoms, we've already gone through some of them, but vomiting more than once, bleeding or discharge from the ear or the nose, fits, seizures, twitching or convulsions, anything like that, blurred or double vision, poor coordination or clumsiness, and this is really from any age once they start moving around. That's a big symptom of a nasty head injury. And severe or persistent headaches, that's not relieved by paracetamol. Any new arm or leg weakness, difficulty swallowing or coughing. So these are all severe symptoms, okay? Difficulty swallowing or coughing when eating or drinking, sensitivity to noise, slurred or unclear speech, or unusual or confused behaviour, okay? Or a severe headache, or if you think that if they haven't stopped crying and you think that their head's sore after a head injury, if they're too young to tell you, then it could be that they've got a persistent headache. Okay, so that basically what I want you to remember from head injury is that you're never wrong. As a mum of a child, you know what's best for them. You know that what's right and what's not right. Like my son has, when he's eating with his mouth full or he yawns, his eyelid drops, and it's really bizarre, but it's just, I don't know if he got caught in the way out or what happened, but he's got it's obviously some kind of injury that he's always had. But sometimes it shows up when he's not feeling very well or he's very tired. And when I took him in with a head injury, they noticed this and they kept asking me, is this normal? And I'm like, yeah, that's because only you know what's normal for your child. So never be told otherwise. Any good pediatrician, pediatric doctor or nurse should be taught from day one, like I was, that always listen to the parents, because you could miss something that you don't know is different. You always listen to the parents. So, right, we're going to go into choking now, and I'm going to stop the share of my screen. Can you see me again? Okay, so, yeah, can you see my mannequin here? She's a bit pale, I know. Right, so I'm just going to pop the screen back here. Everything's done online, so we're just going to do the best we can. Okay, so we're going to go through choking. Okay, like I said, if you think of any questions throughout, pop them in the chat, and if we don't get to them, I will be downloading the chat so that I can keep all your questions and answer them. Okay, so this is say a 4-month-old baby, and what we need to remember with choking is that often we'll be feeding our child, we'll be weaning between 4 to 6 months, they'll start eating, or maybe they've grabbed something and it's gone down the wrong way. Your child has a reflex, a cough reflex and a gag reflex, which are there for a reason. The body's clever. I keep saying the same thing, but I really want to focus on the fact that our bodies very much know what they're doing most of the time. If your child puts something in the mouth or they're choking on some food and they start coughing, if it's a good productive cough, we just need to let them cough. We don't start banging them on the back and making it difficult for them to cough and get up, whatever it is. We just need to let them cough, okay? We need to support them. We can sit them upright and just, obviously monitor very closely. But as long as they're coughing well, we let them cough, okay? That will be enough to either clear the airway or bring it up so they can swallow it properly, all right? Or they'll vomit or something. But that most of the time, that's what they'll do. We need to not interfere with that by banging them on the back. The problem lies if that cough becomes weaker and they're not managing to shift it. So if the cough becomes weaker, or they start making a noise when they're breathing and they're not coughing forcefully anymore, that's when we need to intervene. There is a couple of things we need to do. We need to call an ambulance, we need to do back slaps, and we need to do chest thrusts. Just 3 things. So first of all, if you don't have your phone on you, don't run through the house with a panicked child in your arms because you might fall over. You need to place the child somewhere safe, on their side, on their back if they're not able to sit up. Run and get your phone, come back, pop it on speaker, and phone the ambulance while you're doing the back slaps and the chest thrusts, okay? So with what we can do is you can look inside the child's mouth, and if you can clearly see something there that you think you can get, then you can absolutely go in with the pincer fingers, your index finger and your thumb, and if you can clearly get it, or clearly feel it, see it, then you can try and do that. That's in the guidelines now. It never used to be. We can now go in and have a little try if we can pull it out. If it's too far down or you don't think you can get it, just don't try, because if we push it further down and get it lodged, then that's not good. Okay, so if you see something in there, great. If you can get it out, fantastic. If you can't get it out or you can't see anything, we need to have called the ambulance and started the back slaps first, okay? So with back slaps, we can do this on our lap with a child, probably I'd say like up to a small 3-year-old, we could probably still do this on our lap, but otherwise we would do with an older child, we would do with them sat up and leant forward, okay? So we're gonna go with the younger child for now. And I'll just pretend this is my lap here because my lap's too far down. So we're going to place the child so that the head and the body are in a neutral position. What that means is the head isn't tilted all the way back or all the way forward. It's just supported under the chin here with my fingers as if you're burping. And you've got the head and the body, the whole body just tilt, so all nice and flat, and then the whole baby tilted slightly down the way just to let a bit of gravity do its thing. I'm just going to put my knee up here so I've got something to do it against. Then we're going to use the heel of our hand and we're going to go between the shoulder blades, and we're going to do 5 back slaps or back blows, whatever you want to call them, and in between we're going to slightly twist and check the mouth, because one back blow could be all it takes and it pops up, and we don't want to keep doing this in case they swallow it again, okay? So we're going to go between the shoulder blades and we're going to go 1, check, 2, check, 3, check, 4, check, 5, okay? So here we go. Let me just get a little bit closer so you can see a little bit better there. So we're checking in between each one. After we've done the back blows, we're going to do the chest thrusts. So this can be done on your lap as well, or a hard surface. I'm going to just do it on my lap here. So really important to keep checking in the mouth. This object, whatever it is, could come up at any time, all right? So we're going to do chest thrusts, and we're going to do 2 fingers. We're going to point straight, we're pointing towards, we've got our hand pointing towards the face, 2 fingers. We're going to try and go roughly 1/3 of the depth down, because we're trying to pop out whatever's in there, okay? Again, we want the head in a good neutral position, not too far forward or back, and we're going to go between the nipples. Just always remember between the nipples, okay? So we're going to go 1, check, 2, check, 3, check, 4, check, 5, check. So nothing, okay? Then we go back and just do the same again. So ambulance is on its way. We're just going to continue with the back blows and the chest thrusts, okay? So again, good neutral position with the head, down slightly, the heel of your hand here between the shoulder blades. 1, turn, 2, check, 3, check, 4, check, 5. Now, a good indicator of strength of the slats here is that if you do it with an open hand, when you're doing it hard enough, or you know your heel is slightly stuck out of your hand, if you're doing it hard enough, the tips of your fingers will kind of tap the back of the head. If you're not doing it hard enough, often that won't happen. So don't be afraid of your fingertips tapping the back of the head if you're doing it hard enough, okay? That gives you a little bit of an idea. Also, don't worry too much about breaking the baby. They're choking. It's very important that we try and get whatever it is up. And just know that up to the age of around 18 months, the baby's bones are mostly cartilage. So that means they're very bendy. Quite hard to break a bone in a young baby because they are quite bendy and they're quite cartilagey, if that's a word. So don't worry too much. They are very, very bendy, and that's, you know, all the bones in their bodies. So I'm just going to go through that one more time. So the ambulance is on its way because the cough is now less effective, or maybe you can hear noise when they're breathing, and they're just not managing to get the food up or whatever it is. Okay, so we're going to do back blows first once we've checked for no obvious things in the mouth that we can get up. Okay, so heel of the hand, we're going to go 1, 2, 3, 4, 5. Nothing, so we turn them over. Again, nice neutral position, 2 fingers pointing forward. 1, 2, 3, 4, 5. Okay, still nothing. I'm always checking in the mouth. All right, so that's the back blows and the chest thrusts, and we just keep going. Back blows, chest thrusts, back blows, chest thrusts, until the ambulance arrives. Okay, so they're the only 2 things you need to be doing. Just remember, if the child is starting to struggle, the cough is less effective, straight away call the ambulance. Do not be afraid to do that. Okay, so now we're going to go on to CPR. I'm just going to push this back a bit because we must always do CPR on a hard surface, never on your lap. All right, you need, very, very important that you have a hard surface for CPR. So all CPR should be done on a table, floor, whatever it is. So say if you've got a very young child and you're in a kitchen or something like that, you know, you might find it easier to have them on the tabletop. It just doesn't matter. You just need a hard surface. Often the floor is better because you've got a bigger space. Okay, so I'm just going to put my tea. So with CPR, obviously there's a lot to it. There's a lot of build up with the danger response, send for help. We can't go through all that today because this is a quick masterclass. We do full classes as well. But today is just a brief run through and give you the most essential bits. So all CPR now is 2 breaths to 30 compressions. That goes from newborn to old person. Okay, all breath, 2 breaths, 30 compressions. We do the compression rate at 2 per second. Okay, we try and get down about 1/3 of the depth. And we need to remember that the reason we are trying to do, the reason we're doing compressions is not to restart the heart or fix the problem. It's to continue being that good pump, to keep the oxygenated blood to keep going around the body. Okay, so we need the oxygenated blood to keep in the organs and in the brain. And by doing CPR, we're basically keeping the heart pumping optimally. Okay, the time to start CPR is when someone stops breathing. We no longer check for, we no longer check, let me just close the door, just a second. Disaster, they came home early. Okay, we no longer check for the pulse, and that's across the board. Okay, a pulse can be very hard to check, and we just don't waste time anymore. We now know that by doing compressions, it doesn't actually harm the heart in any way when we do compressions, even on someone whose heart's already beating. So once they stop If someone stops breathing for whatever reason, you come across someone who's breathing, your child's choking, not breathing, straight away we start CPR, okay? We're trying to just make it really simple. It's just one rule, all right? So what we're going to do is 2 breaths to 30 compressions, a third of the depth down, and around 2 per second, okay? With a baby, we need to make sure that with everyone, we need to make sure that the nose is clamped. So we will pinch the nose so that when we put the breath into the mouth, it doesn't just come shooting out the nose. With a very young baby, if you can pop your mouth around the nose and the mouth, but that can be quite tricky. So just know that if you can't do that, then you need to pinch the nose, okay? So I think that's about it, but if I've missed anything, please pop it in the chat, we'll answer it. Okay, so we're going to always do this stood up if they're on a tabletop, so I'm going to stand up, or if they're on the floor, you get up on your knees, because it's always easier to do CPR with your body weight over the person or the child, okay? So we're going to stand up here, and then I'm going to do 2 breaths, and you might see some chest rise here if the camera's good enough. So we'll pinch the nose. 1, 2. Okay, so that's 2 rounds of 2 breaths to 30 compressions, okay? We continue doing this until the ambulance arrives. If the child is choking or the airway is blocked, then the compressions are going to do a similar thing to the chest thrusts. It may still help to remove the object that's in there, okay? But we need to remember always that the baby's airway is like a plastic straw. So this is why it's so important to keep this good neutral position here. With an older child, so sort of age, around about age 2, 3 and up, we might have them in a slightly more of a sniffing position like this. Because they're older, their windpipe is more formed. But a young baby, it needs to be in just a good neutral position like this, so that their airway doesn't kink like a plastic straw. Okay. As I said, the oxygen in the body is already oxygenated in the blood. So what we're trying to do is just keep that oxygenated blood running around the body as effectively as we can, and that's what we're trying to do. What else was I going to tell you about that? So that's it. So at this point, the guidelines are still telling us to do 2 breaths to 30 compressions. But what we now know is that the compressions are about 30, they're about, so 30 compressions, but they're about 80% of the actual resuscitation, all right? So what that means is, if you come across someone in the street who's vomited all over themselves, you do not want to do mouth to mouth, then just know that by you just doing continuous compressions, that's 80% of a resuscitation, okay? So it's really, really, really important. If the baby is fully choking on something and something's completely lodged in the airway and you can't get any respirators through, know that your compressions are doing so much more, okay? So you just continue compressions, all right? So that's our CPR section. Again, any questions, anything I've missed, then I will answer it, I promise you. But remember, across the board, 2 breaths, 30 compressions, make sure the nose is pinched so the air's not coming out of there and it's going in the lungs. And if you're not getting chest rise, then maybe just adjust the head position just slightly, and then maybe you'll see some chest rise, but maybe it's just because the airway is blocked, okay? But we should be seeing the chest rise. You only need to blow in enough that feels, enough sort of air into the baby that fills your cheek. So like, you don't need very much air. You just need to see chest rise. So obviously it'll be more with a bigger child, but as long as you're seeing chest rise, then that's fine. Okay, so we're going to go on to the food bit now, just so we don't run out of time. So I'm going to share my screen again and go to Okay, can you see that? Allergy, yeah. Okay, so introducing common allergenic foods. So obviously we, a couple of us over at the Nest are clinical nurse specialists in childhood allergy as well as pediatric, general pediatric nurses. So it is a special interest of ours, but it's also a major problem in Australia at this time. Not as major as COVID-19, but it's 10% of under 1-year-olds have a diagnosed food allergy now. And that's a huge, for one thing like allergy, that's huge. The good news is that a lot of children under the age of 5, like up to 60-70% of children under the age of 5 will grow out of their food allergies, but some won't. What you can see on the screen here are the 9 most common foods that children are allergic to. Eggs, cow's milk, tree nut, sesame, peanut, wheat, fish, shellfish, and soy. Sorry, there's a typo there. But we don't really know why the rate of food allergy is so bad in Australia. It's the worst country in the world for food allergy, childhood food allergy. It's probably environmental. We don't know exactly, but it's probably something to do with environmental, because we do know that certain nationalities, if their child was born in Australia rather than born in, say, Asia or where they were originally from, their child has much more chance of developing a food allergy born in Australia than born in their native country. So we do think it's something environmental, but as a lot of things could be blamed for environmental, but that's a big conversation. So anyway, until we know that, the good news is the government, was pouring a lot of money into food allergy because it is such an issue. So these are the top 9 allergenic foods, common allergenic foods, and these are the ones that will be on bold on the back of all food packets. It is a legal requirement, okay? So what we say is that there's a, on our social media at the Nest CPR on Instagram and Facebook, there is a post. It's quite a way down. I'll need to put it on the website, but it's quite a way down. But it gives you a way that if you're nervous to introduce common allergenic foods, okay? It's not a specific way that you have to do it. There's nothing wrong with putting a bit of peanut butter on some toast and giving it to your kids. That's fine. But it's just, if people are a bit nervous or they're not sure, then this is a way. And the picture is 4 white spoons on a black background, so it's quite obvious to see. And that's one of our best social media posts, or most popular. So there is a way to introduce foods if you're not sure, and I'll go through that in a minute. But we do now know that it's been proven over and over and over and over again that the best way to prevent childhood food allergy is early introduction of common allergenic foods. So early introduction doesn't mean that you should be introducing foods before 4 to 6 months. It doesn't mean early as in age. It just means when your child starts eating, make some of those first foods, those common allergenic foods, like egg, nuts, peanut butter. As soon as your child starts eating, they can eat these things, okay? Obviously not in their whole form, but you can grind anything down in a blender, or a NutriBullet we use. Wheat, fish, shellfish, all these things the baby can have, okay? Well cooked, obviously, but they all need to be introduced. These top 9 need to be introduced by the 12 months, okay? I've got a question here about parents with food allergies and things and their children, but I'll answer that at the end. So this is a way that you can introduce a food if you're nervous. It's not that you have to do it this way, but if you're nervous, this is a bit of a guideline. So basically, over a couple of hours in the morning, I'd always do it in the morning, you can give the child a specific food that you're worried about in kind of a couple of different doses. So what we would say is anything like nuts, eggs, it's already ground down, or it's in a paste form. We would give 1/8 of a teaspoon, and then once they've had that 1/8 of a teaspoon, you would wait half an hour to see if there's any issues. And then once they have, after that half an hour, you can double it to 1/4 of a teaspoon, and then wait half an hour, and then half a teaspoon, and wait half an hour, and then a whole teaspoon, okay? once you've done that, it's just a structured way to do it. And what it does is it gives you that half an hour to see if there's any kind of reaction at all. Now, some allergic reactions obviously happen delayed or later, but a vast majority of them will happen within 15, 20 minutes. It will become obvious very, very quickly. So that's why we say half an hour, because it gives you plenty of time to see if there's anything. Remember that even though 10% of under 1-year-olds has a diagnosed food allergy, 90% don't. So I wouldn't be too paranoid about it. But this is a way that you can just gently do it, in your own time. We can observe the symptoms. I'll go through symptoms of an allergic reaction with you now. And then I'll answer some questions, especially about allergy as well, and eczema and things like that. So signs of an allergic reaction. This is what an action plan looks like. Someone that has an EpiPen will have one of these, or should have. Everyone with an EpiPen should have one of these, and it basically tells you just near the top there, action for mild to moderate allergic reaction, and then at the very top it says signs of mild to moderate allergic reaction, and then halfway down in red, watch for any of the signs of anaphylaxis. So anaphylaxis is basically just a severe allergic reaction. It's just another word for a severe allergic reaction. So if your child is allergic to anything, as in food-wise, they always have the ability to have anaphylaxis. There is no such thing of having a child that has a food allergy that can be guaranteed that it will never have anaphylaxis, okay? So if there's an allergy there, true allergy that's been diagnosed by an immunologist, then they always have the capability of having anaphylaxis. However, the immunologist might decide that they're very, very low risk for anaphylaxis. So they may choose not to give an EpiPen. So it doesn't mean that every child with a food allergy has an EpiPen, but a lot do. So most do, all right? So signs of an allergic reaction. So this isn't anaphylaxis. These are just signs of a mild to moderate allergic reaction. Swelling of the lips, face and eyes, hives or welts, tingling of the mouth, abdominal pain or vomiting. So these can all be signs of an allergic reaction. Signs of anaphylaxis so this is a severe allergic reaction, difficult or noisy breathing, swelling of the tongue, swelling or tightness in the throat, a wheeze or persistent cough, difficulty talking or hoarse voice, or dizziness, or a young child might go pale and floppy. So swelling of the tongue is not something I've seen that commonly. I've seen a lot of anaphylaxis and I've not seen that very commonly, but a persistent cough is by far the most common symptom of an allergic reaction, okay? And the persistent cough often then will go on to create a wheeze, all right? So if your child has a new food and they have any of these symptoms, then you need to call an ambulance, because any of those symptoms below anaphylaxis, you need to call an ambulance if you've just introduced a new food, okay? And also a common one with very young children is that they go pale and floppy, okay? So it can be very frightening, but it is a sign of anaphylaxis. It's when the blood pressure drops, okay? So swelling and tightness in the throat, some children might sort of grab at their throat a bit. Some might just have like the mild to moderate reaction of a tingly mouth, and they're like trying to scratch their tongue and putting their tongue in and out, and it feels a bit funny. But any of these symptoms, they're on my website too. You can take a look. Then you need to get them seen immediately. The mild to moderate symptoms, you can just book an appointment with your GP and get some advice that way. Skin prick testing is the only way, or one of the best ways to find out if there is a sensitivity to food, and also just seeing an immunologist. Don't get skin prick testing done anywhere that can't kind of read them, can't do anything about the results, okay? There's lots of places out there that I won't mention that do skin prick testing but can't tell you what it means. All right, so you need to be seeing an immunologist, and if you need any recommendations, then ask us here, because we've got many, many, many good immunologist friends. So that's the signs and symptoms of an allergic reaction, okay? So you would call an ambulance. If you have an EpiPen, then you would give the EpiPen as soon as you have any signs of anaphylaxis, but otherwise you would just call an ambulance, and the ambulance will always have adrenaline on board, and that's exactly what a allergic reaction needs. So we're going to go back to, I'm going to go to the questions now. Let's have a look. Oh my goodness, there's so many. There's no way. I've got 62 questions. I don't think I'm going to get through them all, but so I've got some here that people already pre-submitted. So I'm going to do these first. I need to stop sharing my screen. There we go. Right, I'll go back to the beginning. I'll do them in order. Okay, so sorry if I mispronounce your name, but Nurja, Nirja. Anyway, so she says, my bub's 4 months old, looking for advice on starting solids now. I'm vegetarian, but my husband eats some meat. The question is, I'd prefer to keep my bub vegetarian, but will she get enough nutrition that way? I've been pretty healthy. Yeah. So you can absolutely get, so first of all, I'm not a nutritionist, I'm afraid. I wish I was. I've got a great nutritionist friend who's a qualified, degree qualified nutritionist. So if you want her name, I will give it to you. But Dandelion Nutrition actually is where you'll find her details, and she's fabulous, and she's a pediatric nurse as well, so she's doubly clever. But I'm absolutely sure that your child can get all the nutrients it needs from being vegetarian. I think that we live in a world now where that is completely fine and doable. It's knowing what foods to eat to cover all the spectrums there, absolutely. But I can't advise you on exactly what, because it's just not my expertise, I'm afraid. If your bub is 4 months old, you can start solids. All we say is that they need to be able to be holding their head up well, be sitting up well in a high chair. I mean, they do need a little bit of cushioning either side sometimes. They need to have good head control, and they need to be so that they can swallow safely. And they also need to be showing some interest in the food. Okay, so we wouldn't start feeding a child that just has absolutely no interest. They're just not ready. Okay, so 4 months is fine if your baby's ready. They should be starting by 6 months. Okay, so that's that window, and that's when we should also be introducing nuts and things like that as well. So it's never too early for that. So baby-led weaning. So another question from her is about baby-led weaning. So here everyone's saying you should introduce solids before 6 months to avoid allergies. So no, before 12 months. So the early introduction of common allergenic foods should all be, so when we say early introduction of common allergenic foods, we're talking about introducing those 9 foods earlier in life. So under 12 months. So between 4 to 6 where you start, and then up to 12. So we're not saying introduce those allergy foods earlier than anything else. Just introduce them with everything else. But they all should be introduced by 12 months, because we know that that brings down the rate of childhood allergy. Okay. Baby-led weaning, again, absolutely fine. Just make sure everything's boiled or steamed within an inch of its life, so that it's just going to fall apart in the baby's mouth. They're not going to be a choking hazard. But there's no wrong way to start feeding your baby. Just, we need to be careful with lumps, hard lumps, obviously, but we also need to, as you go on with the feeding, to be able to introduce lumps so that the baby knows what to do with lumps. You don't want to keep a baby at 12 months old still on puree. If they should be introduced, you should be putting some lumps in there so that they actually know what to do with them. Otherwise, they are at risk of choking because they don't know what to do with the lump. So yeah, all foods, the only things that you shouldn't be introducing before 12 months are things like honey. And that's not because of allergy, but it's because of like a bacteria that it can have in it. So yeah, otherwise there's not many things that you shouldn't be introducing. And if you are a parent that has food allergies, and you, however severe your allergies are, it doesn't mean to say your child is going to have those allergies. Okay, it's all the more reason that you introduce those foods early on. And also, if you have, there's another question here from Natalie about about eczema. So if your baby has existing eczema, then what you need to do is basically, so if a child comes into our clinic and we're going to feed it a food that we know it's allergic to, but we think that maybe the allergy may have passed, we're not sure. What we do is we have a look at the baby and we see what the eczema looks like before we challenge them. So it doesn't mean that just because the baby has eczema that we won't feed them these foods, but we look and we see where the patches are, we see what they look like. And then if the baby is allergic to that food or very sensitive to that food, the eczema will flare. And it will be quite obvious, like you'll know the difference because obviously you know your child better than anyone. So if he's allergic to the food, the eczema will definitely tell you. The eczema is a very strong indicator that the allergy is still there. However, if there's no other symptoms other than the eczema flare, I would persist for 2 or 3 times to introduce to see if it fades, because it may well just fade. Often when you give it first, it might flare a bit because it's new, and then it fades. So as long as there's no other symptoms of allergy like hives, swelling or anything like that, then you can persist and just see if that dies away. Natasha, can we cover introduction of foods a parent is allergic to? Yes, so no reason not to introduce that food to your child. There's nothing to say. It's very small chance that your child will, so there's a slight increased risk that your child is allergic to that food, but only slight. And we know that early introduction can override that slight increased risk. So get the food in there as soon as you can if you want to introduce that food and if it's going to be in your house. The other thing is that you have to keep these foods in the diet. Once you introduce it, try and keep them in the diet as well. Let's have a look. So a few tech issues at the beginning. Would you give paracetamol at 39 degrees for a baby under the age of 1? Yes, you can give paracetamol to a baby under the age of 1. You can give paracetamol to a much younger baby than that. If it's 39 degrees, I would just go by how they're actually feeling. So if they're in pain, they're crying, they're miserable, you think that there's some soreness there, then absolutely you can give it. But if they're not fussed, if they're still just chilling out, not doing much, not seeming uncomfortable, again, you just don't need to give it. So don't worry too much. Just be led by them and how they are sort of, how they're kind of dealing with it. What else have we got here? How long will you be monitoring a child with a head injury? Really, a nasty head injury normally becomes apparent quite quickly, but if you're worried to the point where you're monitoring them all day long because it was quite a nasty knock, you probably just need to get them seen. After the first couple of hours, I wouldn't be worried that there's anything specifically, but obviously we just never know if something is slowly, going wrong there. So you just need to keep an eye. But if you're worried to the point where you're watching them all day long, you probably just need to go and get them seen and get some reassurance, even just from a GP. So there isn't really a specific length of time. It just depends on the injury and how worried you are. Vomiting once. Why is vomiting once okay, but twice not? So once, because children, especially young children, vomit easily and all the time. They can vomit through shock, fear, crying too much. They've eaten a pea and it's just not agreed with them and they vomit. So children just vomit really easily. It can also be just a stress reaction. So 1 vomit is quite normal. 2 vomits is not as normal. It may be fine, but there just has to be a cut-off point somewhere. So we say 2 vomits or more is not normal. So what if a 6-month-old does a weak cough every time they eat something? So the weak cough that we're worried about is a weak cough that comes after them having a big forceful coughing fit, and it gets weaker and weaker. So it's not that it starts off like that necessarily, but it's very difficult to describe. If that's normal for your child to have a little cough every time they eat, again, that's probably okay because they're obviously stopping the food going down the wrong way, otherwise they wouldn't generate a cough. So the cough that I'm talking about is one that comes after they've had sort of a big coughing fit if something's gone down the wrong way. But only you'll probably know if that's normal for your child to have a slight weak cough every time they eat something. then that's maybe just normal for your little one. With the choking actions for the 3 to 8 year olds, so we basically would just do the same. Sorry, I'm going to have to call it quits in a second, but we're with a 3 to 8 year old, you would just sit them up on your lap or in a chair, and you can just support them at the front with your hand on their chest, and we do the back blows exactly the same way between the shoulder blades. Okay, probably just a little harder with a bigger child. And with the chest thrusts, you can either do them laid flat on the floor. If they're not feeling great and they want to lay down, we can do it chest thrusts on the floor and quickly tip them over if they feel like they're going to be sick. Or you can do it in a chair, but with against the wall, and then you can do the chest thrust sitting up. Okay, but they have to have something hard behind them. So they're either laid down or they're in a chair against the wall. Okay, and that would be the same for adults as well. I explained about slapping hard on the back. So your fingertips often will tap the back of the head, and that's how you know that you've hit them hard enough. It is possible to hit them too hard. I mean, like anyone, you have to be led by what's going to give them a jolt. But like I said, the baby's bones are very cartilage, so very much cartilage, so they are just going to rebound. But yeah, I mean, you want to hit them forcefully, but yeah, there is too hard, but I guess you would kind of know that at the time. Yeah, slightly different strengths for a newborn. Sorry, I'm not reading. Shall we use different strength for younger newborn and for older toddlers to do back slaps? Yeah. So it just depends on the size of the child and the frailty of the child and how old they are. Then yeah, you'll just have to be led by sort of how young they are, how old they are, as to how hard you do it. But it needs to be forceful enough to sort of take the breath out of them a little bit, give them a little bit of a wind. I'm just going to do one last question, then we have to call it quits, I'm afraid. When do you start CPR after how many slaps? You only start CPR if the child stops breathing. Okay, there is no amount of slaps. It's just if the child stops breathing, then we would definitely have to start CPR straight away. Okay. So, all right, loves, I'm going to have to go and stop this now. But you will get this. Videoed. I will send it out tomorrow. And in the meantime, I'll get all your other questions answered as soon as I can. But it's been fantastic. Thank you so much. I've loved it. I'm so blown away by how many of you came. There will be more of this kind of thing from us. We've got to get through the isolation somehow. But in the meantime, take care and we'll speak to you soon. Bye.